let me go on directly. I left you today with these slides showing that I strongly believe for a long time, as well as many other members here, that integrated therapeutic targeting may be the only way we have to accelerate progress to prevent resistance in prostate cancer. And that indeed we have to keep in mind that there are all these different alterations that occur at the same time in the tumor. So I will try to, and that indeed we have to have some preclinical data of its activity and try to come up with clinical trials that will somehow test the hypothesis. So what I'm going to talk about now is the baby steps we took a number of years ago when I had a laboratory, and we were looking at prostate cancer with nothing much to do except for the very last few years, and looked at the molecular aspects of prostate cancer that we had learned from a long time ago, and that we know that the androgen receptor is required to have a prostate in the first place. And there is no prostate without androgen receptor or androgens, and that it is essential for normal prostate cell growth, as well as survival of the prostate epithelial cells. And that with the advent of castration-resistant prostate cancer, androgen receptor, in fact, is one of the drivers, and that there are multiple alterations at the level of the gene and its co-regulatory molecules for transcription of DNA. There's also aberrations at the level of the protein, and there is aberrant activation of the androgen receptor by ligand-dependent mechanisms, which is either by increased affinity of the receptor for other hormones, or promiscuity for steroid hormones, or other intracellular synthesis of intracellular androgens. Actually, yes, I'm seeing the same slide, right? Yes. And then one thing we learned very early on is that there's another mechanism of activation which is ligand independent through crosstalk with a number of growth factors in the cell surface, primarily because loss of PTEN is very common, and the PI3K AKT mTOR pathway was essentially very active and another potential targets. There are also recently we learned about the emergence of splice variants that actually do not require ligand, and although may also be cross-talking with the growth factors, we don't know anything about that yet. And finally, that in addition to these alterations, there's a shift in the androgen receptor activation, whether it's ligand bound or independent of the ligand, in the gene sets that it transcribes. And whereas in the androgen ligand bound receptor, there is more a pathway towards metabolism, expression of differentiation factors and survival factors, and that's why they're so sensitive and undergo apoptosis. In the unbound androgen receptor, the pathways are more directed toward mitosis, DNA repair alterations, and many other alterations that really are associated with the castration-resistant disease. Now, when we look at the therapeutic armamentarium that we have, and we had even to present time, by and large, it's only targeting the androgen receptor ligand and the androgen receptor ligand binding domain. All the other alterations are practically not targeted, and certainly not with ligand independent mechanisms. And you know everything about this pathway, and I'm not going to tell you anything more, because one clear thing has been clear for many years, is that except for very few exceptions, perhaps, there is no cure with targeting the androgen receptor alone, at least as monotherapy. There are cures in combination with radiation and maybe with chemotherapy for some patients. So about 10 years ago, even then, it was apparent that the androgen receptor was dominant in this disease process, and that PTEN loss and the PI3 kinase and other growth factor signaling mechanisms were really very active. So we thought about how do we test the hypothesis that we should do multiple targeting. And this is the way I depicted to myself and thought, well, if we actually try to block, it seemed to me that it was essential to block the ligand binding domain because it's so powerful that I thought that unless we did that, no other agent would be able to overcome the force, essentially the driving force of the androgen receptor in the context of the prostate epithelium. So I thought that we had to block the ligand binding domain. At the time, we only had bicalutamide, and that other options would be to downregulate the androgen receptor expression, or then to test blocking all the different pathways in a sequential way, obviously. But those were the alternatives that we probably had. And if we did that, maybe we could develop two treatment paradigms or different treatment paradigms. One that I was particularly inclined to, maybe under the suggestion of my patients that did not want to go androgen deprivation, and that perhaps we could develop some androgen sparing peripheral androgen blockade in the setting of the rising PSAs. The other one was that since we didn't have any effective therapies other than docetaxel for those that had progressed on these anti-androgens, that perhaps if we took different approaches or combined approaches, we could restore the sensitivity to anti-androgens. So in order to test this in a more formal way, I had many years ago developed an androgen-independent cell line from the LN-CAP cells, which are the only ones that express androgen receptor, are very androgen-dependent. And this cell line could grow in the absence of androgens, like in men. It took me 6 months to get this subline. And it overexpressed the androgen receptor at the level of both the overexpress the androgen receptor and also at the protein at the mRNA level. And then we did microarrays and showed that, in fact, there was differential expression of genes, some that were ligand bound, others that were ligand independent, particularly for the eye cells. But then we looked at the spectrum of prostate cancer and decided that we had to have a more wide spectrum of representation. So the LN-CAP, in fact, represent the PTEN null cell lines. As you can see, it has a very active PI3 kinase pathway. Whereas the RB1 cells, which also express the androgen receptor, they have PTEN, and therefore they're not dependent on the PI3 kinase, but they are dependent on ERK, as you can see here. So indeed, it's the two main populations that I thought would represent prostate cancer. So one approach we took, we thought, well, let's try to do the horizontal targeting of AR and growth factors. And we went in the search of various agents, and I got agents commercially available, others that we could get through companies, and we tested many. We tested also a vertical approach simply by blocking the androgen receptor and using finasteride and dutasteride, or dutasteride, finasteride was in this case, and in fact showed that there was synergy and growth inhibition, that the androgen receptor and PSA went down. However, this we did not pursue, but I see that Mary Ellen Taplin has pursued this as a clinical trial. And I'm glad to see that maybe the results are actually positive. Urologists had been doing this for a long time, so I thought that this was very interesting. We took EGFR inhibitors, but they didn't have any effect. We used rapamycin, and it did have effect, and that would be equivalent to an mTOR inhibitor. But we didn't see that there were many changes in the androgen receptor or PSA levels, and essentially we decided to go and that the AKT, which I'm not sure you see there, remained active. So we got finally hold of an AKT inhibitor, and in the same model, we tested the AKT inhibitor at different concentrations and found that, in fact, was active by itself, whether it was androgen dependent or independent, but more so in the androgen independent, and the androgen dependent, that there was synergy, and that whereas there wasn't in the RB1 cells, for instance. So we decided, and we did a number of tests to make sure that indeed there was some inhibition of the ligand bound and unbound, and we saw that in fact there was a decrease in the androgen receptor and PSA, although it was not striking. As a result of this, we managed to convince CTUP and Merck to give us access to the AKT inhibitor MK2206, and with the help of ECOG and my colleagues that supported this idea, we developed this clinical trial. ECOG actually is 2809 or 2309, and where we decided to test the ability of the MK inhibitor or the AKT inhibitor alone combined with bicalutamide versus bicalutamide in androgen naive, in hormone naive rising PSA at patients at high risk of progression. And the design of the study is shown here, which, as I said, is for high-risk patients with PSA doubling time of less than 12 months, is that in the what we call the experimental arm, they would go on MK206 right away as monotherapy, versus the control arm would be on observation. So we could learn about what would be the effect of inhibiting AKT alone on PSA as a readout of the androgen receptor expression. And then we would put both arms on bicalutamide and observe the overall response at the end of 11 months, hoping to achieve an undetectable PSA below 0.2 or 0.2 or below, which is what you would expect to see with castration, and which is the only endpoint that in the rising PSA would be expected to represent a complete remission, if we believe that that can happen. So that's what we did. We have also as a secondary endpoint a PSA decline greater than 85%, and we are going to report on the study at ASCO, I hope, GU ASCO this year. And although we had a number of tissue correlates, I was told, and this is not the only ones that are there, that we would not be able to do the study unless we removed all the correlates, because the correlates would not be supported. And happily, luckily, times have changed significantly, and we hope to be able to take these tissues that were collected from these patients and see whether or not there are subgroups that would that benefited or not. So we hopefully will gain additional knowledge. The other option, as I mentioned, was what we call reversing resistance to anti-androgens by epigenetic modulation of the androgen receptor overexpression. So, oh, I'm pressing the wrong one. So in this case, after testing various histone deacetylase inhibitors that are just laboratory available, we managed to convince Novartis to give us LBH589, which is panobinostat, which was recently approved for the treatment of multiple myeloma. And they approved this study. It's almost the only solid tumor study that they approved since they started development of this drug. And what we showed, again, was in the same model systems that here you have the androgen-dependent cells that are, sensitive to bicalutamide, are these two lines. And panobinostat has an inhibitory effect, but if you combine it, is synergistic. Now, if you take the EI cells, which have overexpression of AR, as I showed you before, in resistance to bicalutamide, panobinostat was active, but the combination at 2 dose levels was truly synergistic. And when we did the animal model with RV1, we found that indeed it was also synergistic, and at least in the animal model, it was most effective even than docetaxel. We went on to show that the androgen receptor and the protein were decreased, that there were growth inhibition and induction of apoptosis, at least measured by caspases. So we concluded that maybe this was an active combination and it was worth testing in a clinical trial. And we went on to design this clinical trial, which was recently reported at ASCO. And this was a phase 1/2 randomized study using LBH589 at 2 dose levels combined with bicalutamide in men who had progressed on anti-androgens. They were castration resistant and at least had one or more anti-androgen. So the phase 1 was relatively easy. We never reached the MTD. The toxicity was pretty acceptable, and in fact, thrombocytopenia, which is one of the major side effects in hematologic malignancies, was not observed. And so we moved on to the phase 2, and we did a randomized phase 2 where, different from the previous one, we had to test the combination, but at 2 dose levels. As I mentioned to you, the histone deacetylase inhibitors have a very broad spectrum of activities, both at gene level and the protein level, and the doses are probably variable, mainly in combination in different settings. So that's what we did. And we started with a high dose, which was 40 milligrams 3 times a week for 2 weeks. So we also used an intermittent schedule to minimize the toxicity and be able to do long exposure. And then in the other arm, we used a dose that was quite low, 20 milligrams, which we thought might not be effective, given what Novartis knew of the PD and PKs of these drugs. So the primary endpoint was radiographic progression-free survival, because I didn't think, and I believe that, unlike my friend here, that PSA will tell us the whole story, particularly we using biologic agents that work so different from those that are targeting exclusively or only the androgen receptor. It's true that we're targeting indirectly the androgen receptor, but I thought that we should look at progression-free survival as a better endpoint to assess whether or not there would be any level of activity. And that we would call this an effective combinations if we could observe radiographic progression-free in 15% at least at 6 months. So the group of patients we accrued to the studies was indeed castrate resistant. Most of them had metastatic disease to bone or lymph nodes. So there were predominantly castrate resistance. They all had at least 2 or 3 second-line anti-androgens and had progressed through them, including some patients had docetaxel because it didn't exclude. And the toxicities of the agent was quite grade 1 and grade 2 primarily, and was higher at the higher doses, which prompted us to early on decrease the dose from the 40 milligrams rapidly to 30 and to 25 milligrams in order to make it tolerable over a long range of time, particularly because we noticed that the 40 milligram dose, the toxicity primarily being either fatigue and in some cases diarrhea, led many patients to stop the study when it could be managed very easily simply by decreasing the dose and still maintaining what we consider to be a reasonable dose for this trial. So what we observed in a nutshell is that indeed the PSA responses as waterfall plots were not really very impressive. And I show here some of the changes in PSA. What we mostly saw in the patients that we follow longitudinally was a change in PSA doubling time. And I put this patient here because this was a patient of mine who had been on every single agent, including chemotherapy, this one too. And what we saw is a significant change in the PSA doubling time. And this man who started in the phase 1 was on the study for about 2.5 years without evidence of radiographic progression. And this man, for instance, had been on both hormones and chemotherapy. And again, it took some time to get a response, but eventually it declined. And even today, I have lost follow-up since I moved. He has been off any other additional anti-androgen or chemotherapy since that time. So what we did observe was that, in fact, in the arm B, that is the very low dose, was ineffective, didn't meet any of the endpoints, whereas in the arm A, where we had the high dose, the highest dose, although rapidly and frequently reduced, at 6 months, there was a significant improvement in terms, at least greater than 15%. It was about 30%. In terms of radiographic progression-free survival. So we concluded that this delay with the combination was indicative that there may be a group of patients at least, and I'm sorry I don't have the progression-free survival curves to show you, because I think that for the future I'm going to follow that recommendation, not just show the waterfall plots, because it's more telling than when you see this. And that when you see the waterfall plots, it's really very disappointing. And my impression is that obviously today we have agents that are much more potent, such as enzalutamide and all the new anti-androgens. And given the new therapeutic armamentarium, it's likely that the combination as we tested it would not move forward, but certainly suggests that there is a modulation of the androgen receptor activity by histone deacetylase inhibitors, because these, remember, are highly resistant patients to bicalutamide and all the second generation. Perhaps something like that or use of this type of approach in combination with enzalutamide, and I'm not showing here data, would not only delay the progression, but maybe even suppress the emergence of splice variants. So that's something that will remain to be tested, and certainly we will have to learn in what context to use it. So thank you very much, and these are my collaborators in the laboratory that led to these clinical trials. Translational.